Hi, everyone. This is Stacy Chazen, and I'm very happy to join you all today and super excited to be moderating today's session, a fireside chat on anti-racism and LGBTQIA+ oral health equity. Our speakers for this session today are Dr. Eleanor Fleming and Dr. Annalise Cothran, and I'm going to tell you a little bit about these two phenomenal individuals. Give me a second. Dr. Eleanor Fleming is a diplomate of the American Board of Dental Public Health. She earned her dental degree from Meharry Medical College, completed her dental public health residency at Boston University, and earned her PhD from Yale. She completed additional postgraduate training as an academic intelligence service officer, where she investigated disease outbreaks and conducted studies to promote health. Over the course of her career, she has developed subject matter expertise on infectious and disease epidemiology, and previously served as the dental epidemiologist overseeing the work of the National Health Agency. She has been the principal investigator in a number of studies and has informed public health surveillance at state, national, and international levels. Dr. Fleming holds leadership positions in the American Association of Public Health Research and the American Public Health Association, where she completed a term on the APHA Science Board. She was also actively involved in the National Dental Association, serving on its coronavirus task force. Welcome, Dr. Fleming. Dr. Annalise Cothran is the co-founder and executive director of the American Institute of Dental Public Health. She received her Doctor of Sciences from A.T. Still University in Leadership and Organizational Behavior and a Master of Science from Mississippi State University, specializing in experimental psychology with a theme in applied statistics. In her current capacity, she directs AIDPH toward mission success in advancing oral health equity. Dr. Cothran serves as a board member for Texas Impact and the Texas Oral Health Coalition while supporting the Oral Health Progress and Equity Network as a regional oral health connection team lead and facilitating the LGBTQIA+ work group. Dr. Fleming, Dr. Cothran, it's my honor to be joining you for this session today. And I will turn it over to you to get us started. And before I do that, actually, I am going to remind the audience to please post any questions in the chat box, and I'll be lifting those up for our speakers as we go along. And we'll do our best to get to every question either during the session or following the formal remarks by our presenters. But we want this to be a conversation, so please share your thoughts, share your questions. We want to hear you in the chat box, at least. Thank you.
Well, thank you, Stacy, for that very generous introduction. Very thrilled to be here and to share what I think Annalise and I both agree is a very important topic as we think about oral health equity. So what I'm going to do and what we will do together is kind of do some level setting to make sure that we have the same understandings of terms and kind of can engage in this conversation together. Before doing that, I just want to acknowledge that we don't have any conflicts of interest to disclose, and we just want to state that very clearly. So as we think about this idea of oral health equity, in my opinion, it's important that we kind of make this shift from thinking about disparities to thinking about equity. I've used a screenshot here from the National Academy of Medicine to help us have the same language. So in my mind, when we think about disparities, at the end of the day, we're just talking about differences. Typically, these differences are preventable, and we're basically are describing a burden of disease. As we think about oral health disparities, we can think about typically people of color, people of lower socioeconomic status, often people in rural settings. They bear the burden of disparities. But in describing those disparities, we are essentially just doing that work of descriptive epi, which is just describing. Our focus often is on health equity. And we think about health equity as not just describing the disparities, but trying to figure out why those disparities exist and how we can work sometimes in the space of social determinants of health to advance practices that make health available for all people. Right? We often think of health as being this transactional service where we go to these people, members of the dental team, to receive these services, and hopefully they leave us in this place of health. But health, as we know, operates on a continuum. And as the videos were showing, as we think about fluoride and the many ways that we get fluoride, whether it's from community water fluoridation, water from the tap, various mechanisms, all of that is a part of equity and ensuring that everyone has the opportunity for optimal health. Another piece of this, and I love this figure, and I use it quite often because it makes the point that the equity isn't about giving the boxes to people so that they can see over the fence, right? If we think about equality, that's giving everyone a box so that they can see over the fence. We can think about equality being giving everyone access to oral health care, whatever that may mean. If we think about equity, and equity in the context of making sure that everyone has access to optimal health, addressing population level health, not everyone needs a box, right? Some people need the box, some people don't need the box. To the point of the videos that were airing, if your oral health provider suggests that you may need extra fluoride, that's probably true, but not everyone needs that. So equity is in many respects tailored to population needs, burdens of disease, and historical experiences. But what's striking is that equity isn't enough. Sometimes we have to take down the fence so that everyone can see. Now, in this figure, that's called liberation. Some call it social justice. Others just call it doing what we need to do to make sure that everyone can see the field. Everyone has the opportunity for optimal health. And I offer to us, as we gather kind of in this oral health summit, think about the great oral health plan that the state is using to think not just about describing disparities. We know how to do that well, but to think about equity, and equity in the context of social justice, liberation, and what it means to do this work of supporting populations in their optimal health. So where does this leave us in terms of anti-racism? So anti-racism is a term that we often see in social media. Maybe you are reading it in your newspapers, wherever you get your news, wherever you get the information that you use to make evidence-based decisions. But at the end of the day, let us be clear. Racism is a public health problem. And being anti-racist means being a part of fighting against racism. Whether that racism is directed towards people of African descent, we can think about efforts to elevate Black Lives Matter. Whether it comes in the context of standing against Asian hate, or whether we're doing the work to make sure that we are very inclusive and including American Indian Alaska Natives and other marginalized communities and populations. And you know who they are, right? It's going to look different from you in Idaho than perhaps it looks for me here in Tennessee. But the fact remains is that racism is racism as racism. And we know that that creates a significant barrier. It is a significant fence that I don't know if there are enough boxes that can help us to see over the fence. So what I'm asking or suggesting that we take up as our mantle is taking down racism. And I've used a resource here that you may find to be unusual, and that's the National Museum of African American History and Culture. And if you're looking for a resource that can give you the information in the context of what is usable and easy to understand and grounded in a context of both history and culture, I highly encourage you to use these links and to see where there is additional learning that may be necessary. So racism is structural, right? It's not just how one interacts with me as a Black woman, right? Prejudice, implicit bias, all of those things that we think about operating at the levels of individuals. While that is important, what we know to be true is how I am treated, how our colleagues who happen to tick another box that is different from ours is treated may not be the issue. What may actually be the issue is how implicit bias is engrounded in structurals and institutions, creating structural racism. That goes from everything about the assumptions that we make, the language that we use, histories, practices, policies. All of this feeds into those disparities, which again, don't happen by chance, that are totally preventable. And again, how we can situate ourselves in this effort to be anti-racist, in this effort to be intentional about confronting racism wherever we find it, whether it's racism in our workplaces, and you would know better than I who is included at the table when you're making decisions, which communities are engaged as equal partners and collaborators, which communities may be presented as victims, as people who are just difficult patients. You've heard the language before. Hopefully you haven't used it, but if this is language that you've used, if these are observations that you've had in your own settings, know that there's a choice for you to do better, right? There is a room for improvement. And adopting some anti-racist strategies, being inclusive in how we approach doing this work, becomes very important to how we can create spaces for equity, and especially equity around oral health. And with that, I will turn it over to my colleague to take us the next step in our level setting.
Thank you so much, Dr. Fleming. And for these purposes, we've made a decision to use first names so that we can remain very conversational. And we hope that you all feel invited to this conversation too about these really important topics. So thank you for starting us off, Eleanor, on this really wonderful rooting and grounding into why this work matters. And hopefully my goal here today will be to layer on more information onto what Eleanor has already presented for us to consider how communities within the LGBTQIA space are impacted and how oral health equity may look for that community. So that's my goal, is to do some level setting, and we can go to the next slide. So I am not going to read all of the things on here because it's a lot, but I like to present this slide because inevitably, whenever I speak to communities, to specifically in oral health settings, when I use the acronym LGBTQIA+, it inevitably people say, oh my goodness, I'm not quite sure what one of those mean, right? And so here we are right in front of us, kind of level setting on terminology to begin with. Because this community is actually really, really diverse in and of itself. And I want to show that the LGBTQ plus community is not a monolith because it is so diverse and there are so many different communities represented just within that acronym. And so some of those are related to sexual orientation and attraction. And in the next slide, I hope to be able to clarify whenever I use terminology about heterosexual or non-heterosexual or transgender and cisgender. Hopefully this can lend us some again, level setting and clarity about how we'll talk about the LGBTQ plus community. So I love this. I love this visual. And I actually think there's an updated one. I just saw it the other day and I should have put it in here. So there's the Genderbread Person 2.0, and I encourage everybody to look at that one. That one just came out. But what's really important here is to understand when we talk about sexual attraction, when we talk about gender identity, that these things manifest in many different ways. And some of them are very biological, and it's important for us to understand that. And so our gender identity, which is there on a spectrum, and people can feel free to identify anywhere along that spectrum that they want to, our gender identity is actually biological. It starts in our brain. And every person goes through a gender affirmation process starting at a young age. Usually this happens anywhere between 3 or 4 to 7 years old, you start really affirming your gender identity. I, at that age, affirmed that I was cisgender, meaning that the gender assumed at birth, when I went through my affirmation process, that was correct for me. For transgender people, the gender that they were assumed at birth, when they go through that identity process, and sometimes that happens early, sometimes it happens later, when they go through that affirmation process, the gender assumed at birth does not match their gender identity. And so that is a non-cisgender or transgender person, and that is a very biological process that happens. Now, how I choose to express that gender, that might be the pronouns that I use, that might be the clothes that I wear, how I decide to name myself, etc. My physical manifestation of my gender identity is my expression. And that is, again, very varied, has a lot of diversity, and people feel free to express their gender in many different ways. So I think we all understand biological, we understand biological sex, and sexual orientation. So I was going to skip those over. So Eleanor actually did the right thing by advancing to the next slide to talk about why this is important. It's important because LGBTQ+ people have been marginalized for a very long time. It is not uncommon, and it is not uncommon in the oral health community for us to extend what societally is oppression for this community. And it's really important that if we as oral health equity champions want to make a difference and want to do what is right by providing resources, support, and affirmation to underserved communities, we need to focus on this. And that's because the LGBTQIA+ community, and you can move to the next slide, Eleanor, they experience a significant amount of health disparities. And I want to point out that unfortunately, there is just simply not enough research that really quantifies all of the oral health manifestations associated with stigma, with discrimination, some of the things that Eleanor talked about already in this presentation as it relates to minoritized communities, also relates to the LGBTQ+ community and the outcomes that they experience. So what I don't like about how we have approached this in oral health is that far too much of what we focus on are outcomes as it relates to sexual health and well-being. And far too often, we relegate the entire LGBTQ+ community into that particular area, recognizing that this is a whole person health approach that we need to take. And so that means lived experience, the entirety of their lived experience. It means that we have to take mental health and all of that into consideration as we approach an oral health and well-being, for the LGBTQ+ community. And so while I've talked about there's been a significant amount of discrimination that this community has experienced, I want to point out more directly in this next slide that this is ongoing, and it is right now, and it is happening across the country. So you may or may not know that in the 2020-2021 legislative cycle, that more than 30 states, and really almost every state, has offered in some way an anti-LGBTQ bill. So policies that are harmful and damaging to the LGBTQ+ community have been offered in most states. They've all looked differently, but it's part of a nationally coordinated effort to end gender discrimination, and it's almost predominantly aimed at transgender children. And so this is not a coincidence. This is part of, again, a nationally coordinated effort to sort of copy and paste the same bills into every state. And it's aimed at transgender children because it's just been message tested and politically viable to do that. I am in the state of Texas, and Texas is actually leading the country in 70 bills and counting, bills that have been introduced against the LGBTQ community, and 70% of those are aimed at children, whether that is taking away transgender children's health care, whether that is preventing them from playing school sports, whether that is making parents of transgender children child abusers. We are leading the nation in this really harmful and dangerous rhetoric. And so one of the calls to action that I hope you can leave here today is just learning more about what's going on in your own state of Idaho, and how that impacts the LGBTQIA+ community. And so I will end there and hand it over to Stacy to help direct the conversation moving forward.
Thanks so much, Annalise and Eleanor. I will admit that I had heard some of what you'd shared before, and so much of it is new to me as well as I expect it is for our participants here today. So first, I want to remind our audience, our participants, to please use the chat box to post any questions that you have. We have a good deal of time remaining to be able to field any questions and really go into any discussions that you'd like to see us explore a little more deeply. I will start off, Eleanor, with a question for you. For some folks who might not be familiar with the notion of racism being a public health issue, I wonder if you could say a little bit more about that and what that looks like.
So as we think about racism as a public health issue, it's important that we acknowledge where we are in the pandemic. And I invite us all to just take a moment and to pause, to remember those who have been lost, to remember those who are struggling in the midst of the pandemic. Thank you for that moment. And I start here because I think the pandemic in many respects has shed light, right, on how racism impacts people in different ways. So if you think about in the early days of, last year, where the burden of disease was, as we think about who has access to vaccines and who doesn't, all of this is related to racism, right? The fact that I'm worried as a dental epidemiologist that I would die from COVID, not because I'm not healthy, but because if I get sick and if I happen to find myself in the wrong hospital, they may not hear my concerns of not feeling well, what my symptoms are, or even know how to treat me as an individual. And if you're like, oh, Eleanor, you are making that up, girl. That has not happened any place in the United States ever. No. Just this winter, there was a physician in Ohio. I'm blanking on her name at the moment, but she got sick, a physician with COVID, and from her hospital bed was live streaming from Facebook how she was not treated well in that setting. And she ended up dying. So here is a Black woman, a physician, who fell to COVID. Some could argue because of racism in the healthcare system. Now, it should come as no surprise that when the hospital system did their investigation, it was like, oh no, that wasn't racism, but we're going to give our providers some cultural sensitivity, and really they followed the standard of care. Maybe, maybe not, but I trust her, right? And I trust what she shared in terms of her treatment. So to say that racism is a public health crisis is to understand that in the midst of a pandemic, all lives do not matter, right? Some people have borne burdens not because of their DNA, not because of their genetic code. And just so that we're clear, this thing that we call race, this thing that we call racism, only has the meaning that we give to it. We know that there is basically no difference between people, but how I'm read as a Black woman and how Annalise may be read as a white woman, that whiteness and that Blackness only makes sense in society, and society that puts that into work in ways of maintaining hierarchies that lead to disparate outcomes. So to say that racism is a public health problem is looking at morbidity and mortality. It's looking at whether your state even reports data at the level of demographics to include this thing called race. It's looking at where there are barriers to care and not barriers that are maybe always obvious, like transportation. Sometimes if you live in a place that has had a history of redlining and historically keeping out peoples, how has that translated into the 21st century? And there's a great book that I want to encourage people who want to learn more, and it came from the American Public Health Association. And it's called like Racism, a Public Health Practitioner's Guide. And it takes you step by step in understanding the history, some of which I've offered here today in terms of understanding the past, but also ways in which public health practice, medical practice, dental practice by extension have perpetuated these systems. So to say that racism is a public health problem is a crisis, is to see the entirety of health on a spectrum and the many ways that, again, people carry burdens that they shouldn't and only carry those burdens because of systemic oppression.
Thank you for that. And it's so valuable to think about that, both in terms of social determinants of health and the inherent bias that we see in providers, in looking at barriers to healthcare overall. Can you also take us down a little more granularly if we're thinking about oral health care specifically? How does that show up? What does it look like?
So oral health is an interesting one. And it should come as no surprise that oral health is a little late, shall we say, in coming to recognizing racism as a problem. And what I mean by that is the literature that tells us the degree to which racism impacts oral health is very sparse. So I can tell you all day and twice on Sunday, the prevalence estimates, the disparities burden. I can tell you all of that good stuff. Well, not bad stuff, but I can tell you all of those data. But what I can't get to, and where there are these limits, are the degree to which racism impacts oral health. So there is a body of literature that is lacking in the United States. But when we look at the literature in other countries, what we find is that in Australia, Aboriginal women or Aboriginal people who are pregnant, who go to access oral health services, report experiences of discrimination that are linked to their oral health outcomes. Right, there are studies coming out of Brazil. And again, there's kind of this global body of literature that tells us that for people who present as Black, Brown, Aboriginal, however they are described in those nations, the care is just different. One of the better studies from the US was actually set up where you have the same patient, same radiographs, same chief complaint. And the only thing that differs in the patient is that one has a picture of a woman who would identify as white, and one is a picture of a woman who would identify as Black. And the question becomes, when presented with these data of a patient with a chief complaint of this tooth right here hurts, what is the treatment plan? Is the treatment plan to endodontically treat the tooth to save it? Or is the treatment plan to extract? And more often than not, the woman who presented as Black was given we're just going to extract. And for my dental colleagues who are here, my practicing dentists, you know that extracting a tooth leads to the question of when are we going to replace? Because missing teeth, edentialism, are more likely to occur among Black people, right? So that is just one example of where provider bias translates into differential oral health outcomes, and we can follow what that might mean for an individual or a population. But again, there's sparse literature coming from the United States, but I'm hoping that there will be greater interest to actually engage the question of how does racism, how does a patient's experience with discrimination and prejudice lead to different oral health outcomes, and not just different, but oral health outcomes that lead to worse oral health status and health status.
And I'm wondering too, part of that research, I would think it would be interesting to see the impact of that patient experience on the patients, how the patients choose to move forward and interact with the healthcare system moving forward. Would that be fair to say, or a good question to ask?
Absolutely, Stacy. And I think, and Annalise, please join me in this conversation, because I have seen studies looking at the LGBTQIA+ community that shows that when members of this community go to access health care, and when that experience is one where they feel marginalized, not heard, not accepted, othered in a way that they just stop accessing services, right? And so I think that there is this sense to which how people are treated, or at least their perception of the treatment, layered onto historical policies, structures, all of these ways in which that othering, that marginalization, again, I use the language of oppression, operates. You see people backing out. They're like, I don't want to access a system where I'm going to feel bad, not feel heard. But I'll leave it to Annalise to speak to perhaps experiences and literature that demonstrates this.
Yeah, and Annalise, before you start, and that was actually a great segue, and we didn't plan for this, but one thing I'd really like to see, because folks might be wondering, why are the two of you here together? Like, how do these two topics fit together? I wonder, in considering that question, if you could also talk a little more broadly about what the intersection, what the overlaps are between racism and discrimination against the LGBTQIA+ individuals and communities in this context, in terms of what it looks like, the impact that it has. How is it similar, and how, if in any ways, is it different?
Yes, thank you. I feel like that set us up for such a great discussion. And I think to Eleanor's original sort of call in, number one, there are not enough data out here. So it's very similar when we're talking about structural racism and the outcomes that we see on oral health. There just simply isn't enough focus in this area. And so that is a particular call to action for researchers, for oral health professionals, and equity advocates to spend more time, energy, and resources into really understanding the whole approach in oral health outcomes. So that's one area of alignment between what the LGBTQIA community faces and structural racism. So I also think too, we need to recognize that this is not only about the patient experience while they're in the chair, because so many patients don't get to that first step. And that is very common, particularly among transgender people. The research I'm understanding is that up to 70% of transgender people in certain areas do not go to the dentist, do not go to their medical providers because of a fear of discrimination. And so that stigma means that they are delaying or totally foregoing medically necessary care because they are scared. And that's just because, one, of course, there are cultural biases associated particularly with transgender people. And there are prejudices associated with treating that community that we as providers have to address head on. How it's described to me as a transgender person, and I am the mother of a transgender child. And so while I am cisgender, I can talk about my particular experience in terms of taking my child to the dentist. And whenever they show up to a dental appointment, I have to clarify pronouns, even if I've done that in advance. So most of the time I call a medical provider, I call a dental provider, and I say, my child uses XYZ pronouns, and my child's name is this in the system. Can we make sure that we're, affirming them before we even get in the door? And even when I do all of that work of trying to come out on behalf of my child and shield them from any unnecessary embarrassment, 90% of the time, the dental office still gets it wrong. The medical office still gets it wrong. That's unacceptable. We have to make sure that we are teaching our professionals to affirm all of the patients that step into the office. So even when we do the pre-work, it's really disappointing when my child is misgendered whenever they enter a dental office. And I think there are a lot of overlapping experiences of being othered in terms of race, ethnicity, racial experience. And there's an overlapping inequity experience between the two communities. One of my, one quote that that has stuck with me, it's actually from the National Rural Health Association. They put out a paper, I think in 2014, about what they called overlapping or intersecting. I can't remember the exact terminology that they used, overlapping inequities in rural communities. And the way that they phrase it is that it is hard enough to live in a rural community, and it's even harder if you're living in a rural community and you're Black and you're gay. And so it's these types of identities that layer on top of each other that, again, has nothing to do with the individual, but has to do with the systems of oppression that are connected to that. And I actually just want to do a really specific call out to the language that Eleanor was using. We're talking about not minority communities whenever we talk about LGBTQ or Black communities. We're talking about historically excluded communities, meaning that people like me who have lots of privilege, I'm white, I'm cisgender, I'm upper middle class, there are lots of, I'm heterosexual, there are lots of identities that I experience that give me privilege. And so the gatekeeping that is associated from those places of privilege is the actual problem. It has nothing to do with the communities being the problem, yet they disproportionately experience disparate oral health outcomes because of the systems of oppression in which I participate as a person of privilege. And so therefore, it is then my obligation to dismantle those systems of oppression.
If I may, Stacey, just to add on to that, and thank you, Annalise, for kind of dissecting out and building back up. Because the language that I bring to this isn't necessarily overlapping, even though it's the same idea, but it's intersectionality. Like it's this idea that, oppression is oppression is oppression as I see it. And wherever one person is excluded, you can expect my big mouth to be there to say that that is wrong. How are we going to fix it? Because that's not the world, the community, the oral health system that I want to operate in, right? I'm operating in a place of inclusion and allowing people to be their best selves, how they present. The problem of all of this becomes just at a granular point. Again, as we think about not just accessing care in terms of who gets to see a dentist, a hygienist, a therapist, or whomever you're seeing to deliver your care at that moment, but who even has access to the prevention up front, right? I mean, we think about community water fluoridation. And I think that we will all touch and agree that community water fluoridation, as the U.S. Centers for Disease Control and Prevention have argued for years, is one of the best public health successes that we have. But we know just that idea of accessing safe, clean, fluoridated water is not available to everyone. And that's a question of whether you're living in a rural community, whether you're living in Flint, whether you're living wherever you are, if you don't have access to the primary prevention, the thing that we know is going to give you that leg up in maintaining your oral health, what in the world do we think is going to happen once we get to those systems where there are those gatekeepers, whether it's the gatekeepers of payers who say that we only want to reimburse at this level, whether it's the gatekeepers of the providers themselves who are like, nah, I don't want to go into that underserved community. I want to stay here in the suburbs, in the city. So if you start to tease away the multiple systems, the multiple gatekeepers, what you're going to see is that while we're talking about this as though it's racism, as though it has something to do with how people present, identify, how their brains support them in being their best selves, know that this is something that, for me to be blunt, that this is a white people problem too, right? This is not Annalise and I preaching to the choir. Like, this is something where I hope everyone can think of an example. And again, safe water is kind of something where I think we all agree community water fluoridation is important. But when people don't have access, and when that access is within the context of history, and when that access is in the context of history, culture, and context, we have to do the work of asking why and figuring out, to Annalise's language of calling in, how are we going to be willing to call in and show up with communities to do better, to make things more accessible, more equitable, and hopefully to have that type of health and that system of equity that we've all been talking about since the first Surgeon General's report came out in 2000. You know, when can we turn that into a reality?
Great, thank you. So I'm actually going to ask our tech support to help us out here. I understand there are some questions in the chat, but I'm not able to see them. How can we see those? And I guess as you're working on that, I hope. Okay, here we go. So how does, and so we're getting some questions here, some requests for some guidance. So how does one speak openly in the office about these issues in the most comfortable way?
So I can start off that conversation because AIDPH somewhat recently, I believe we did this in June. We actually hosted a workshop on transgender oral health and well-being, and really it was to provide some resources for the dental community to signal more affirmation to the LGBTQIA+ community. Because again, thinking about those folks who won't even enter the office due to fear of discrimination and discomfort. It's at that point, it's not about who has insurance. It's not about who has access. It's about how do we get people to feel comfortable utilizing services, and how are we making sure that we are creating a space that they are also feeling empowered to manage their oral health when they leave, that we are partnering with them as a whole person. And so the suggestions that were actually given in that workshop, and you can find it on our YouTube channel for free. I would highly encourage you to check that out. Dr. Michael Farmer, who is a dentist and working in North Carolina, talked about what he does in his dental office. So number one, he has a rainbow flag. He has a rainbow flag outside of his office. So just as an open and visible signal that he is an affirming provider. Number two, his office staff are trained. They are trained on how to use the correct pronouns, on how to deal with insurance differences, that if somebody is presenting this way, and legally or on their insurance card, they are identified another way, how do you ensure that they are affirmed? And what does that process and that language look like? He also pretty openly goes to and financially supports gay pride events, if there are health fairs associated for the LGBTQIA+ community, how is he as a healthcare provider actually engaging with that community? And not so that he can run up his business. It's so that he can signal that he is an affirming provider. And I love the suggestions that he gave. And for me, I found those as very helpful resources because they're very clear-cut actions. This isn't nebulous. This is here's step 1, 2, 3, 4, 5, and they're easy to do and don't really cost you anything at the end of the day. But Eleanor, I'm not sure if you have any suggestions on how we can actually create more inclusive spaces within the private and or public dental spaces.
And Eleanor, before you answer that, I'll just expand that question a little bit to one of the questions we have from a participant is that as a dental health provider, how can I play a more direct role in preventing policies that may contribute to increasing health disparities to already marginalized populations?
All right, so here's the secret. Here's the secret. Are you ready for it? Don't be racist. Don't be racist, right? So think about, I saw that there was a webinar, a CE happening around difficult patients. And in my mind, I was like, difficult? Like we have a sense of who presents as the difficult patient, but are they really difficult, right? Are they difficult or are they non-compliant? Are they non-compliant or are they just needing more information in order to make decisions? Are they showing up late to appointments just because they can't tell time? Or is it because if they happen to live in an urban setting, they've got to take 5 buses to get to your location, or they had to find someone who could drive them into your clinic for an appointment? What do I mean by this? Think about your language. Think about the biases that you carry with you and check them. And it's, I hate to be so like to the point with it, but being anti-racist starts with you. It starts with the language that you use. It starts with how you engage with people and whether you're willing to engage with humility. Right. I'll be the first person to say, like, I don't have all the answers. I don't go into spaces thinking that I can fix it. I go in to listen. I go in to listen and to try to understand. And I'm not saying that that is going to fix everything, but it starts there. And it also starts with an awareness in your workplace, whether it's your public, private clinic, whether it's your community organization, wherever you happen to be, who is there? Right? It's striking to me that I go into a whole lot of spaces where I am the sole Black face. Why? Like, is it that I was the only one who got the invitation and decided to roll through? Is it because I'm the safe person who people want to engage? So think about all of the spaces that you are in and how they can be more inclusive. Now, to the rubber meeting the road of where can you use your power, your privilege, the place where you are to do better? The question becomes, how much of that capital are you willing to expend? Right? Are you willing to raise your hand during a meeting and be like, hey, why are we talking about XYZ community? Shouldn't XYZ community be included and be given up space in our decision-making table? Are you going to your state health department and saying, hey, we actually need data that's disaggregated so that we can understand the burden of disease in our 3rd grade oral health surveillance system that allows us to see all of the differences in community? Then the big question becomes when you see these bills that Annalise has mentioned that are going through legislatures, or when you see policies that are coming out, and if you read them and are like, that feels like that's going to exclude people rather than include them, are you going to lend your voice to speak for health? Or are you going to stay in the cut and be like, not my problem, I'm good? So a lot of this, I think, boils down to one, checking yourself and doing a self-assessment and knowing what's in your heart and what's in your head. Two, educating yourself, being willing to be vulnerable, to ask questions, to learn, to engage with communities where maybe you've never engaged before. Three, being willing to create spaces for other people to come in as partners, as collaborators, as equal decision makers. And then four, taking it to the people, taking it to where those decisions that are being made, and you know where it's happening, and where can you do the influential work of making sure that health is a part of policies, that anti-racism is a part of policies, and doing some of the corrective work around history and exclusion and doing better where you are. Right? We can't fix it all. I don't have the magic wand to be like, I want dental benefits and Medicare and I'm going to make it happen as one person. No, but you can be a part of collective efforts to ensure that that happens.
Yeah, and I love you started with just don't be racist. That's secret, right? And that doesn't mean just don't, say racial slurs or participate in hate crimes, right? It's so much more than that. And I think a lot of what you just spoke to, Eleanor, is about trying to recognize your own implicit bias, or not just looking at intention, but looking at impact of policies and behaviors. And that could be a whole, I want to say a whole day in and of itself, but it's certainly even more than that. But thanks for opening the window to that for people to be starting to think down that path a little bit.
And one more thing, if I can add, Stacey, like as we think about the corrective work, right now, without giving the numbers, we know where burden of disease is, right? We know where there are populations that are carrying more untreated caries than other populations.
Mm-hmm.
And if we are true to, I think, what most of us as dental providers and oral health advocates, if we're going to walk the walk that we say that we're about, it's figuring out how we can provide services and connect people to care and to do the work of getting those services that people need. And sometimes it's not just seeing the dentist. Right? Sometimes it's making sure that, I don't know, that your Medicaid system is expanded to include adults so that they're not going to the ER, but they can actually come to see you. Sometimes it's about you saying, why, yes, I will be a Medicaid provider. And yes, I am going to make sure that my office is available to these communities. Like we know in our dental toolkit all of the ways that we can both prevent disease and restore people back to health. So as it comes down to being data driven and where we know burden of disease is, it's also being mission driven and action focused to bring services to people. Sometimes you got to meet people where you are, right? Sometimes flying that flag at your office isn't going to get the people in. Sometimes you have to go to the people and the community, show them that you are a trusted place where they will be cared for and affirmed, and do the work one person at a time, hopefully one community at a time, if you can use the tools of advocacy to get that systems level change.
Thank you. Annalise, we have a question that I think you're best to take on. Someone's asked if you could talk a little bit more about identifying yourself with your pronouns.
Yes, I would love to talk more about that. And it actually sort of hinges on what Eleanor was just mentioning. And that is, one, recognizing the areas in which you have privilege so that you are more ready to spend your privilege. And I think that's sort of what Eleanor is saying, is when you are in positions of power, privilege, and have the potential to gatekeep, figure out how best to spin that down and not gatekeep. One of the ways that we do that within the LGBTQIA community is, again, I am cisgender. And so my assumed pronouns match my gender expression usually all of the time. So people know that I use she, her pronouns because my gender expression is traditional, what people would consider female or feminine. And so there's usually not very much confusion about my assumed pronouns. And so the way that I spend my privilege is I introduce myself with my pronouns really frequently. I'm Annalise. I use she, her pronouns. I put that on my Zoom screen name. And whenever I go into a healthcare provider's office with my child, I introduce myself. I say, hi, I'm Annalise. I use she, her pronouns. This is my child. These are the pronouns that they use. And so that's actually a great way as a provider to start off every conversation, regardless of whether you're in front of a cis or transgender person, is to actually start off that conversation in the context of, I'm here to affirm who you are, I'm meeting you where you are, and that you're not treating cis and transgender people different here, because this is really about igniting a conversation that everybody in the end benefits from, and using those inclusive practices consistently and encouraging all your team members to do the same thing. But I think in that same vein, calling more attention to how you can spend your privilege. I really love that Eleanor did that and gave us some really clear ways that we have the ability to do that. The advocacy piece is really important. And in Texas, that is where I've spent most of my time. And what I see is really, really effective on these transgender bills. Yes, is to see, parents and to see transgender people themselves going up there and talking about it, because we have been the most affected by the bills introduced in our state. But the things that come to mind, actually, and specifically about the bills that attempt to remove transgender children and students from playing sports, again, just reframing and reminding us that there's literally zero evidence. There is not a single case in any state anywhere that indicates a transgender child has received some sort of competitive advantage. And so this is not based in science or fact, it's based in discrimination, right? But the things that stuck out to me when I go to these Senate hearings and House hearings and I testify, I remember the cisgender athletes who stand up and say, these transgender athletes are not harming me. The transgender community is not harming me. I am in no way oppressed by these people. And in fact, you're the ones doing the oppression. And that is such a great way of coming to the advocates and standing in front of them and saying, I'm going to spend my privilege and you will not weaponize me in order to oppress others. And that's an opportunity that we as oral health equity champions, we all have that. It doesn't have to be in the specific context of going to talk to a legislator, although that is helpful when you have the ability to do that. Spending your privilege can come in very simple ways, like putting your pronouns on your Zoom name. Those are very easy ways that you can start removing the wall that Eleanor talked about, just one chunk at a time. And it doesn't cost you anything at the end of the day.
Thanks, Annalise. I know that in my work in the organizations I've worked with, I see an increasing number of people when they're getting on a Zoom call, particularly the facilitator, encouraging folks to add their pronouns, their preferred pronouns, if they feel comfortable doing so. And then you start to see all the names changing in the bottom right-hand corner. And not everyone, but and that's fine. But people are just beginning to think about it, at least, which is it's really nice to see.
Yeah, I agree. And again, that is probably the easiest and first way to start. I know whenever I speak to communities, particularly cisgender communities, and they say, I'm just so nervous to engage. I don't know the right language to use. I'm so scared that I'm going to say the wrong thing. And I think those are valid concerns because it probably comes from a place of wanting to do right by other people. The intention is there. And then the fear of harming another person is probably stopping us from putting ourselves out there and spending that bit of privilege, right? And so I think the easy ways to do that are adding your pronouns to all of your public communication. Put them at the end of your emails, put it on your Zoom name, put it on your websites. These are easy ways that we can engage people. And when I'm thinking about, as an oral health provider, if I want to engage the transgender community or the LGBTQ+ community at large, again, those are those easy places of visibility that you can signal to them that they are affirmed when you come into your office. But I will also say, do not put your pronouns and fly your flag and tell people to come and see you if you haven't done the work first. So it's not just about changing your logo during the month of June to a rainbow color and saying, I've done it, I've been inclusive. This has to be a dedicated and authentic investment that shows through your everyday work. And I'm sure Eleanor feels the exact same way. Anti-racism is not saying I showed up at a George Floyd protest last year, so I've checked my box and now I'm anti-racist. Absolutely not. This is a journey we are all on, and probably forever, and bettering our authentic investment to make sure these communities are actually included, and that we have done the work both ourselves and within our organizations and institutions to ensure that continues.
So I'm looking at go ahead.
No, I was just going to say, and if I can add, like, one of the things that I thought Annalise said so skillfully is the fear that people have in making mistakes. As I said before, like, we don't have all of the answers. Just yesterday, I was emailing something to Annalise, and I used the wrong term, and I was like, I knew when I was sending it that it wasn't right, and she just gave me a gentle correction and was like, no worries, but this is how you need to say it. So my point is, we have to be vulnerable in this work, and you have to be willing to educate yourself, to ask questions, and to ask questions from a place where people sense that you're coming from not just to fly the flag in June, not just to remember that we're celebrating Hispanic Heritage Month, so you have your Taco Tuesdays or however you plan on doing that, but making this a part of the walk that you take. And I believe this, and I will believe this until I find evidence to the contrary, that if we do the little work well, and we're all doing the little work, that's going to lead to big changes happening. And maybe they won't happen in our lifetimes, but at least we're creating a path for, again, for equity, for a place where everyone can be included, where we're not talking about the same old disparities from 20 years ago, that we're actually closing the gaps and improving oral health.
So as we're wrapping up, and we were generously given 5 extra minutes to share some final thoughts, where can folks go if they want some more support around this, to learn more, to get some tools, to continue their thinking and learning in this space? Do you have suggestions?
I will go first by saying I love to go to Fenway Health's website. If you don't know Fenway Health is the largest employer and provider of healthcare to the LGBTQIA+ communities. They are a healthcare clinic in the Boston area, and they have a ton of resources on their website for clinicians. There are not enough, maybe just a few resources for oral health providers. However, most of the resources that you'll find there will carry over. So that's number one. Number two, AIDPH does have a dental public health virtual resource center, and we have a whole folder on LGBTQIA+ health. I'd invite you to look through that folder and take what you can from that. And again, I mentioned our YouTube videos if you're looking for workshops or the recording there. The last thing I'll leave you with is please go to the AIDPH website. On the homepage, scroll all the way to the bottom, and you'll see the Equality Act Toolkit. So that is a toolkit that we have put together for the oral health community to engage in advocacy on supporting LGBTQIA+ people. There's very specific language about the health outcomes experienced in this community, and whether or not you actually talk to any legislators about it, specifically senators about it, you can at least get some advocacy toolkits, tooltips for how to move forward in supporting this community.
So I think from an anti-racist perspective, again, I highly recommend the American Public Health Association book on racism and how to engage in this work as a public health professional. Specifically for oral health, the American Association of Public Health Dentistry released a white paper this summer about anti-racism in dental public health practice. I highly encourage you to read that. And if you're just looking to learn more about anti-racism and just kind of one-stop shop, Boston University actually has a Center of Anti-Racism, and their resources, their webinars for healthcare providers, for health systems, for students, for whomever are great. There are webinars, there are other learning tools. So those would be the three go-to sources that I would recommend.
Thank you both for this wonderful, informative, educational, eye-opening conversation. It was a pleasure to engage with both of you. And thanks to our audience for the thoughtful questions.